Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the $1 Million Minute. These are the things that kind of help to get my practice to the $1 Million mark and beyond. So today I'm recording for a Monday, the patients from a Monday. There were 16 patients. Now I had 2 hours and 20 minutes. So I keep telling you this. This is a new office, and so there's less of a demand in this new office than the other office. So we have two offices. I'm at this new one Mondays and Wednesdays, so it's a little bit slower. And I kind of try to use this time to do some marketing. So I'm going to talk about a few things that I was working on today. So I did a talk a few weeks ago to a group of primary carers called Charles River. All they do is primary care, which is kind of a nice group because there's no podiatrists and they have to develop relationships. So I was struggling with something. So after the talk, I reached out to them and said, hey, could you give me the list of all the primary cares in your group that are nearby? And they sent me this list. Now, there are certain tasks that are, I think, easy for us, and there's other tasks that are challenging for us. So for me, one of the challenging tasks is to call up and see if they want information, see if they have a doctor that they refer to, just because it's probably something that we shouldn't be doing as podiatrists, because our time is better used something else, and it's just very uncomfortable, right? You really want, when you're talking about positioning, you want to have someone else position you. And our staff are really good for that. And I was kind of struggling. I was like, do I just send them letters? Do I send them a little kit? What in the world do I send these new doctors? And how do I get off of my butt and just do something? So as I was sitting there, I had a staff, and a couple weeks ago, her name is Reagan, and a couple weeks ago I gave her a list. I printed out all the diabetic patients, for example, that I hadn't seen in the last between 2 and 3 years out. And she called them up and reactivated a lot of patients. And it was really easy for her. And this is something and this is a key. If something's easy for someone, there's always something easy for someone else that's not easy for you. Okay? And this was really easy for her. So I was like, well, could she do this for us? Could she just take this list? So I gave her this list. It had maybe 30 doctors. And I said, okay, you take this, call them, just see if they have a doctor that they refer to currently that can get patients in the same day. Because that's one of the benefits right now, because we have a new doctor starting, so we have a second office. We can usually fit people in the same day, which is not common for a lot of other doctors around here. So I think it's one of those USPs, which is a unique selling proposition. Getting people in, I think sometimes is even better than being really good, because if you can't get in, you're going to go see someone that's more available. So I think availability is something that's important. So she did this. It's super easy. I thought it was stressing me out just to ask her. She did it. And then she also helped draft up a letter. There's a couple other inserts we're going to put in there. One is what we can do for you, meaning it's just a list of stuff that we can do as podiatrists for their patients. There's a list it's a referral sheet, so if they want to fax over this referral sheet. And I got this idea from a vein doctor that this is what they use. So I have a referral sheet. Then a brochure for us, and then some business cards. So that's what she's going to send out to all these doctors, their offices. And she called up everyone, and they all were happy to add this to their list. And in this letter, I also asked them if they would add us to their referral list. A lot of doctors, they have these referral lists. They just put, for example, if they want to send out to specialists, they just have a list of specialists. And I just want to make sure our name is on there, because that's the only way they're going to be coming to see us, unless they come from the internet. Okay, so that was one good thing that happened. Another kind of embarrassing thing, I want to share this because I like to share the good, the bad, and the ugly, is I forwarded my domain, drpelto.com. So we switched it and we merged it all to our website, Central Mass Podiatry. We did this, months ago now. And I was struggling with forwarding the web pages. So I had a lot of pages, for example, on my YouTube that were pointing to drpelto.com. Well, all those got broke. And if you know anything about SEO, that was super horrible. But I couldn't figure the darn thing out. So, and I was struggling. I went a few times to this web domain host called Hover, Hover, where I use it. And I couldn't figure out the darn thing. And so yesterday I had some time, and I put it in the chat and said I need help. I had this dumb AI thing that didn't work. And then eventually they sent me to a rep through the company. And in 30 seconds, because I had forwarded to HTTPS, which is secure, and they can't do the S. So they just took out the S's, and all these domain forwards worked. So I guess the lesson there is I probably could have saved a lot of angst if I would have just asked for help earlier. So if you have something that like frustrates you, try to give it to someone that's better than you to do it, or ask for help. I think that's key, because I think a lot of times we have these lingering things in our lives for our practices that just don't get done because we suck at them. And there's usually someone better at doing most things than we are, except treating patients. So just something, if you're like struggling with stuff, like write down a couple of options and just ask someone for help. Okay, let's go into the day. This is a kind of a heavy EPAT day because this is a Shockwave day. So first patient, he was on EPAT number 5 of 6 for Achilles tendon. He also had an amnio injection, I think, on the second visit. He's doing much better. He has one more left. He's feeling very good. Next was EPAT number 2 for plantar fasciitis. She's already starting to feel a little bit better. I think sometimes that's just from the tissue flexibility and mobility. Next patient was, that was for plantar fasciitis. The next one is EPAT number 3 out of 6. This guy has posterior tibial tendinitis / possible little bit of a tendon tear, but he is getting ready for a sacred hike he is doing. It's a 40-day hike where they do about 8 to 9 miles a day, and he is preparing for this. I made him orthotics. He's wearing like a high-top hiking boot to protect his tendon, and he just has a lot of swelling in that area. So I'm doing the Shockwave. There might be a little bit of a split tear in that posterior tibial, but he is not wanting to do anything right now, so we're just getting him through this with these Shockwaves. So he is number 3 of 6. Next patient, this is a patient for ankle arthritis. This is number 6 of 6, so I'm going to see her back in 3 months. Usually arthritis, I see them back a lot longer because arthritis takes longer because of the bone marrow edema. But this one here, it was interesting. They have an insurance called Fallon, and they actually got the Shockwave covered. I was pretty impressed because not many people are getting Shockwave covered, but they reimbursed her for her expense for that. So I was happy and a little bit like unsure of how to deal with this, because we've had some patients that are getting the Shockwave covered, for example, for Medicare, but it's not really clear, and it's a little bit challenging for staff, like whether or not we bill insurance, whether or not we bill the patient, whether or not they ask for a refund from their insurance. Okay, next patient was this patient was a hammer toe follow-up. So she came in 6-week follow-up for a fracture. The fracture is totally doing better. She has a hammer toe on the 3rd digit that is bothering her, and she needs a flexor tenotomy. So we're going to plan on doing a flexor tenotomy in the future. It was the 4th digit. And she also, due to her foot type, she has a very pronated foot type on one side with that flexible hammer toe, and then the other is a little bit normal. And because of this as well, she's having a hard time walking with her balance, so we scanned her for orthotics today. And then the last patient, this was EPAT number 2 of 6. This is a gentleman that has a little bit of Achilles and plantar fascia pain, and he was actually feeling better after the first one. Afternoon, this was a Shockwave. This is a presurgical one for a patient that's going to be having bunionectomy to help with the soft tissue kind of remodeling after the surgery. Next patient was follow-up. This is a patient that was on Lamisil, didn't work for 30 days, no improvement, put them on diflucan, and then I did see improvement in most of the nails. There's a couple of the really big, thick dystrophic ones that aren't doing well, but he's really not really interested in doing more medication, and he's pleased with the results. Next patient was a 61-year-old patient, new patient with left heel pain. So this is kind of she is a patient that had on the left foot a previous fusion of the first, second, and third cuneiform joints at another institution, and now she has plantar fasciitis on that side. Actually, that was the previous one. This one actually had a first MPJ fusion and on the left, and now is having plantar fascial pain and some Achilles pain. So because of this patient kind of has kind of a high arch, putting a little bit more strain through the fascia, and we did an orthotic for this patient, did an x-ray, and we talked about doing possible Shockwave in the future. Next patient, I had 2 patients. This was kind of frustrating. I had 2 of my carry flexes that fell off, and those aren't fun because when we talk about most valuable patients, that was not it. These are probably like the least valuable patients because I only did an office visit, and I don't charge to reapply this if it falls off within 3 months. So I had 2 of those yesterday. So the lesson there is I'm going to start having my CariFlex patients in, even when they fall off, to come on my Friday mornings when I have my nail tech, so that she can do those for me. Next patient was probably my MVP, my most valuable patient. This is a patient, she's a 44-year-old female, got an x-ray, did an ultrasound on her Achilles, and she has some Achilles tendonitis. She's been doing some longer runs, like 30K runs. She runs 5 to 6 miles a day. She's having a little bit of swelling in the on the ultrasound on her Achilles in the mid portion section. And because of this, she doesn't want to be down. She wants to continue to run. It's good for her mental health, she says. So she's going to be doing 3 Shockwaves. So I set her up, and I did the first one. So I think with Shockwave, it's good to do the ultrasound right away the same day, and then if you can, do one of the treatments the same day. So we did that for her. Next patient was another new patient that had some neuropathy, and she had a callus. So I treated that callus, got an x-ray to look for any bony abnormalities, and recommended for her as well a high contouring orthotic, because she has a cavus type of a foot, and it's putting a lot of pressure on the 1st and 5th mets and also on the heel, and so I recommended as well orthotic for her. Next patient was a patient that had a fracture on the right foot, so she got a cam boot on the right, and so x-ray, office visit, cam boot on the right for that fracture, so fracture code I used, and then on the left she had a wart, and we did cantharidin on there. So it's kind of a complex one. Now the question is, do you do fracture code for the procedure, or do you do just office visit? I tend to do more fracture codes, but the challenge is then you can't do office visits for the cantharidin in the future, so we'll just do the procedure for the cantharidin in the future. This other one was the CariFlex that came off, and then the next one was a EPAT number 1 of 6 for plantar fasciitis, and then there was a Shockwave follow-up. This is a patient, she had bilateral, she's actually my neighbor, she had bilateral insertional Achilles tendonitis that's been going on forever. And it's kind of painful. I find with insertional Achilles, they need 6 sessions. 3 just isn't enough. She's here. She did a 6-week follow-up and another 6-week follow-up. She's better, but occasionally she still has some pain. And that is a challenging condition. I only did 3 sessions only because it was so expensive. So if you think about it, 3 sessions for me is 3 sessions on both sides is $1,500, and that would be another $1,500. So that was kind of the challenge with that patient. But being a neighbor, I did, and I think we all kind of do this with others. And I said, well, if you want to do a few more, you just come in, we'll do an office visit, and I'll do the Shockwave for her if she wanted to do that in the future. Okay, so that was the day. Once again, if you guys want to get any resources on Shockwave, you can see this was a really busy Shockwave day. I would go to podiatrypracticemastery.com/shockwave. All my resources are there. Kind of explains what tools I use, how they work. They work very well in practice, and happy to answer any questions that you have. Okay, thanks.